Our next speaker is Xavier Loria, who's Medical Affairs Director from Santhera Pharmaceutical, who is going to speak on Santhera's real-world experience with Idebenone and LHON, update on programs.
Good morning or good afternoon already, I lost count. Yes. I'm very honored and very pleased, and I'm very thankful to be here. I think it's a great audience and it's a great event, so I'm very happy to participate in it. I subscribe what Dr. Katz has said. I mean, we are all in for this, so we all put our little bit of information into the pot in order to cook something that can help everybody. What I'm going to tell you about today is, first of all, this is my disclosure. As you have heard, I've worked for Santhera. And one thing is I'm going to be talking about a product which is not available in the United States. It's not approved for use yet, but it's approved for use in Europe. And thanks to that approval, we've done further research. And what I'm going to present today is the latest results or findings that we've found for analyzing the data. So I'm just going to talk about, we're going to take 3 steps. First, data on this expanded access program, as I said to you. Then for the post-authorization measures that the European authorities negotiated or imposed on us in terms of, yes, we will let you market your drug in Europe, but we want you to carry on collecting data, collecting evidence, because we still need to know more. So on that, those programs, I'm just going to give you a very brief update. And finally, I just want to highlight that there are external publications or publications by external experts which contribute to the knowledge and to the proper use of proper management of the disease, I would say. Right, just briefly to remind you about Idebenone, antioxidant. The problem is complex 1 in LHON. Electrons are there in a kind of a traffic jam. They cannot circulate to the rest of the respiratory chain. That causes problems, reactive oxygen species, and on the other hand, the energy that is needed might not be produced in enough quantities. That causes, again, a problem in the retinal ganglion cells. Eventually, they might lead into apoptosis, but Dr. Newman has told you about that. I'm just trying to explain in a graphical way what is this, what is shuttling electrons. This is more or less what I found. This is a model, actually. So you would have a lot of commuters stranded and, not going where to go. So someone decides to invent this thing. I don't know whether it is really working or not in real life, but you put the commuters on top of this thing and you just go over the cars. At the end of the day, you reach your destination, which is what you want to do. So a year ago, I was here and I was telling you about LEROS, which is one of the post-authorization measures, one of the studies that we are running. The United States centers are participating on it. And because of that, I just gave you a brief introduction to the disease, which I don't need to do that now, about the drug, which I don't need to do that now. But one of the things that I can say is Dr. Katz is still going through the crossing of the desert in some way. You are in the research stage. We've gone past that. We've already reached the oasis in some way. There is water after all this thing, and we'll wait for you there. I mean, it is worth the effort to walk this path, but it is not easy. Was not easy for us. We designed a clinical trial that could have been foolproof in some way or fail-proof. It didn't get enough good results in terms of statistical significance, but it gave us a lot of learning. So I think that we all learned from that. Then we move to the next step. Any kind of minute piece of information that you can get that can justify, explain, or provide more data to explain the results, the findings, that is very helpful. That's what we did with the Expanded Access Program. And then, very important, natural history. We think we know, we don't know enough. So every little bit of information is crucial for us, for any other company, and for the patients and physicians. Finally, we reached that other end of the tunnel. We were authorized, but again, we were asked to do further research, which is what we are doing. Not easy again because, well, placebo is, well, not accepted in some countries where the drug might be available. The other thing is, we are talking about a rare disease, so not easy. In that sense, we need to deal with whatever we come across. And one of the things that we came across was, number one, the LEROS study, which I'll touch briefly later on, and number two, the Expanded Access Program. Expanded Access Program started back in 2011, and it has a reason. When the first results were published, there was an interest in using the Idebenone in patients with LHON. So we had a number of requests by physicians worldwide in several areas and several countries in order to treat the patients, which we accepted, which we obviously provided the drug. There was no precondition in some way, so it was real clinical practice. So each physician would decide, except for the dose that we recommended, 900 milligrams per day in 3 divided doses, how frequently they would see the doctor, how long they would treat. That was decided by the physician, the treating physician. But after a few years, we decided to collect data, because this is actually what happens in real life. And it's very important data. And that data helped us to support the claim of the product in front of the European authorities. But also now, in the latest cutoff, the last year, about a year ago, we collected again data, updated to that point, and this is what I'm going to present. Briefly, just to mention a couple of things. The way we measure efficacy is by outcome. Here is clinically relevant recovery. So a minimum change in the improvement of the visual acuity that is considered clinically meaningful by many physicians. Whether you are on chart or off chart, I'll show you now. But the other thing we also want to look is those patients that are still better than 2200, I mean better than less than 1 logmar, to try to keep those eyes in that visual acuity level so that they don't deteriorate into the legal blindness. This is the way we measure it. On the red side, let's say you see the clinically relevant recovery. We account for patients that start treatment off chart and patients that start treatment on chart. So that if a patient starts treatment off chart, it's not enough to come on chart, but we ask at least to see one line in the ETDRS chart, or the equivalent logmar. If a patient is on chart, at least 10 letters improvement, that's 2 lines in the ETDRS chart, or 0.2 logmar. That would be for recovering lost vision. Now, for maintaining the current vision, which is less than 1 logmar, then what we ask is to, when you start the treatment, you are less than 1 logmar better than 2200, and by the end of the treatment, or by the last observation, whenever it happens, you're still in that level of vision. So we got 111 patients treated worldwide. So in terms of safety, we have a nice number. Everything is okay in that sense. But in terms of efficacy, we only got 87 because some patients were treated and were never followed up. We also wanted to look at the main mutations, and what I'm showing on this table here is just the main characteristics of these 87 patients, which compose what we call the efficacy population. I'm not going to go in detail, but the ones that understand the data will see that this is very much in line with what we have in the real world for LHON patients. In terms of treatment duration, I just want to highlight that we have patients that were on treatment very short time, less than 3 months, but there are patients that have been on treatment for nearly 5 years or 5 years already. Now, then we ask the questions, in terms of preventing legal blindness, in terms of those patients that are still seeing better than 2200, can we prevent that? We saw some signs on the LEROS, the clinical trial that I've just briefly mentioned earlier on, but hold on a second, low numbers, 6 patients on the treatment side, that doesn't take us anywhere, no patients, 2 patients in placebo. But it's interesting to see that in the real world, we observe that kind of preventive of deterioration. So 50% of the patients that started with that level of visual acuity were prevented from crossing the threshold of legal blindness over this period of treatment. Now, the other question that we asked when we designed the analysis of this data was, can we recover visual acuity? So can we have clinically relevant recoveries? This is what I'm showing quickly here. And we see on the left of the screen the total of all patients. The average is 47% of the patients that were treated had a recovery of the visual acuity at that threshold of 2 lines when you are on chart, or they went from off chart, on chart, and able to read 1 line. So that's overall, and then we have the split by mutations, we see that that effect is observed regardless of the mutation. Obviously, 1444 seems to be a better responder, but that doesn't mean that the other ones didn't respond. So, in terms of safety, as I said to you, nothing new. I mean, whatever was shown in the RODOS clinical trial is still valid. We have basically nasopharyngitis, cough, mild to moderate diarrhea, but all of them mild to moderate, and no new safety concerns. Now, I could end here and say thank you very much, etc., but that would be a missed opportunity, because one of the important things that we realize is that when you have this bulk of data, you can still ask some more questions. You interrogate the data, and then you have interesting things. For example, we were told by some physicians that some patients seem to deteriorate at the beginning. So they seem to go down despite of therapy. So we wanted to look at the data and ask, is this true? Is this real? Well, on the screen you will see the 3 colors. If you can see them, it's the green would be the patients that are less than 1 logmar, so above the threshold of legal blindness. The yellow would be patients that are on chart but worse than 2200, and in red you would have the eyes that are off chart. So on the red, if you follow the red lines, what you can see is that because these are individual eyes, and we know that these eyes, we only took the eyes that responded, so we have certainty that they had the CRR, we see that some eyes that later on responded, after starting the therapy, still went down into a kind of a nadir. So they still deteriorated. That is important, whether it is confirmed or not, to bear in mind, because that might induce some patients, some physicians to maybe overreact, to stop the treatment too soon. So the reading of this data would be, don't overreact, just let the treatment do, stay for a while, and then evaluate after a minimum time of treatment. The other thing is, can all eyes in some way, whatever they are in the visual acuity, respond? Without making any claim, what we can see here is the eyes that are on the red dots, which are showing eyes that are off chart, they can still, as we can see, they can still respond, and they can still respond in some cases to better than 2200 logmar. So the reading for this would be, yeah, I mean, basically any eye can respond, so don't limit the application. Another very important question that we receive often is, how long should I treat before I see any effects? And what we've seen here is that some patients respond pretty quickly, 3-6 months, but other patients take longer. And here on the graph we show the global, but also the different mutations. And what I want to just draw your attention is that RODOS, the clinical trial, which was in theory perfectly designed, etc., only lasted 6 months. If you look at this graph with this real-world data, you see that 6 months can only account in the 11778 mutation, probably for about 40-something% of the patients that finally responded. So definitely, maybe we can say that RODOS was too short, and if we had to repeat it or do it again, I would probably go for longer. Here we confirm that the 14484 seems to respond faster, but you see, some patients can still take nearly 2 years to respond. So it's a long time. But this is an observation. This, I'm just put it here for the physicians that are used to this type of graph, just to see that a patient might respond, but the second eye might take still some time to respond. And this is what we see here. When the last patient has responded on the top line, we still see a few eyes responding after that. That's good to bear in mind. Now, The other question is, because we have physicians that treated the patients for a very, very long time, so we have long-term data. The question now is, if I keep on treating, do I reach a kind of a plateau in which there is no further improvement, or in fact, is there a further improvement at some point, or once you reach CRR, that's it? Well, what we see here is by mutation and by the total group, on the left you have, at the moment that the patient reaches the CRR, so we confirm that there is a CRR, we see the logmar indicating what is the magnitude of the improvement at that point. And then next to that we have the last visit, which gives us the magnitude of the improvement at the last visit whenever it happened, be 3 months later, be 5 years later. And what we see is that all across the mutations there seems to be that an effect in which if you maintain the therapy you can still reach further improvement. At some point it's going to plateau, that's going to happen. But this is an important observation. Now, and just coming to a close, one of the things that we observed, trying to find signs on why some patients respond, why some patients don't respond, obviously without being able to make any claims here, we found that patients that didn't respond, maybe they were stopped too early. When you look at the graph, you see that at 6 months, the red line, which is the patients that didn't respond, were still there. But after 6 months, there is a huge and quick attrition of patients, which probably were stopped because of the lack of response. At that point, we were not sure about this 6 months, or that treatment needed to be longer. Anyway, coming to an end, the LEROS, I wanted to tell you, it's still on. We are on course. We are 50% of the enrollment done. We are on the right path, and we expect to finish as planned, and that is going to provide very, very, very valuable information, because what I've shown you now, we will be able to confirm whether that is true or not in a very well controlled way. Anyway, in terms of inclusion, exclusion, you can meet me outside offline and we can talk about the criteria. But I would say that obviously the physicians that are participating in the LEROS, those are the best source of information about this. Now, just to conclude, I would like to highlight this international consensus. It's very interesting, very important for the disease, because it's a way of drawing attention to the need of doing things in an organized, in a well-controlled way. There are going to be new clinical trials, there are going to be new products hopefully being successful, and that is going to require that we know what to do, when to do, how to do it at every single moment. And with that, I'm not going to put the conclusions, etc., etc. Thank you very much, and I'll take any questions later.